guys, I'm Shanmugapriya, your lecturer, and today we are going to see a case study on applied anatomy of humerus. So this presentation will explore a clinical case scenario involving a humeral fracture, emphasizing the crucial role of applied anatomy in diagnosis and management for orthopedic surgeons, anesthesiologists, and senior medical trainees. So here the case presentation is the patient profile. We are going to see about the patient data. So our patient name is Mr. Ramesh, and he is of age 42 years and sex male. Occupation is construction worker and in New Delhi. So his presenting complaints were severe pain in the right upper arm, inability to move his right arm, and also swelling and deformity is seen in the midshaft, numbness and vis drop on the affected area. So, Mr. Kumar's presentation highlights a common occupational injury with significant functional impairment necessity in immediate and precise medical attention. So, now understanding the trauma, Mr. Kumar sustained a fall from scaffolding approximately 10 feet high, landing directly on the outstretched right hand. This mechanism of injury transmits indirect force proximally along the limb. He reported an immediate snapping sound at the time of impact, followed by complete inability to move the affected arm. This suggests a sudden complete disruption of the bone integrity. So his symptoms were like with the inspection or with seen through the normal naked eyes, visible swelling and deformity, abnormal motility were noted at the midshaft of the right arm, characteristic signs of displaced fracture. On palpation, we found out the tenderness was localized over the middle third of the humerus, with a crepitus felt upon the attempted passive movement confirming bony fragmentation. Neurological assessment, significant weakness in the wrist extension and inability to extend fingers were observed, consistent with the radial nerve palsy. And then sensory loss was also present over the dorsum of the hand. So, with the combination of these localized signs, the neurological deficit points towards a complex injury requiring detailed assessment. Radial nerves vulnerability. The development of the tingling or weakness of the wrist extensor soon after trauma strongly suggested potential radial nerve involvement. Automatically, the radial nerve spirals closely in the radial groove, also known as spiral groove, and on the posterior aspect of the humeral shaft. This immitant relationship makes it particularly susceptible to the injury during midshaft humerus fracture. Fracture patterns, especially transverse and spiral fractures, can directly compress, stretch, or lacerate the nerve, leading to characteristic motor sensory deficits. Confirming the fracture, the radial findings, standard anterior posterior, that is AP view, lateral views of the right arm were obtained. Images revealed a transverse fracture at the midshaft of the humerus. Crucially, there is no displacement of the shoulder or elbow joint, confirming the injury was isolated to the humeral dysphasia, and midshaft humerus fracture with radial nerve palsy. So the final diagnosis of our case scenario is midshaft fracture of right humerus complicated by radial nerve palsy. So the diagnosis underscores a classic scenario for orthopedic trauma in high incidence of radial nerve involvement in the middle shaft humeral fracture due to its automatical course of spiral groove. And then the resulting functional impairments, particularly vis drop due to paralysis of the wrist and finger extensor muscles. A hallmark of this complication detects specialized management strategies. Emergency management. So there are mainly 3 emergency managements, and the first one is immobilization. and U-slab plaster splinter was applied to the affected limb to provide immediate stabilization and pain relief. And then we are going to see about the pain control. So analgesics including opioids were administered to manage severe pain effectively. Then comes the neurovascular monitoring. Continuous monitoring of radial and ulnar pulses as well as motor and sensory functions of the hand was initiated to detect any worsening of nerve or vascular status. Prompt emergency management aims to stabilize the patient, alleviate pain, and prevent further injury or complications before definite treatment. Next, definite management and prognosis. So surgical intervention says that indicated due to radial nerve palsy and Mr. Kumar's occupation requiring full arm function. Open reduction and internal fixation, that is ORIF, with a dynamic compression plate and screws. Then intraoperative radial nerve exploration for release or repair. Postoperative care and outlook. The pain management, antibiotics, and early physiotherapy fracture union represents in 12 to 16 weeks, and the radial nerve neurophaxia often recovers within 3 to 6 months. Good long-term prognosis with other two rehabilitation protocols. Applied anatomy in practice. So anatomy guides, these are the takeaways. So it guides that applied anatomy of humerus is indispensable for understanding the typical fracture patterns and anticipating associated neurovascular complications. Radial nerve vigilance. Radial nerve involvement is a prime example of how specific anatomical relations directly dictate clinical presentations and necessities. Tailored management strategies. Optimizing the outcomes promote recognition, precise diagnosis, and appropriate management, significantly improving functional outcomes and patient prognosis in these complexes. In the next class, we will be seeing another case scenario on various topics. So stay tuned. Thank you.